Hello, I'd like to talk today about underserved care. This short video will highlight the need for underserved care by providing background information on the subject. When the video concludes, we'll be able to discuss more in depth any issues that you'd like to follow up with in a question and answer session. I'll start off by pointing out that the need for underserved care is growing every day. Homelessness has increased more significantly in high-income countries over the past 30 years. On any given day in the United States, it's estimated that there's 2.5 million people that are homeless. The homeless median age in the United States is 50, and that number will increase every year as the population matures. Homeless patients have poorer health status than the general population. This is due primarily to significant comorbid factors such as substance abuse, which is estimated to be at 40% within the homeless population, and untreated mental health, which is estimated to be at 60%. The underserved population has barriers to care, and those include difficulty keeping appointments, primarily due to transportation issues, a lack of health insurance, and a fear of discrimination or judgment. The underserved population also has barriers to compliance of treatment plans. And that can include the effects of medications, which increase vulnerabilities to things like theft and assault. Neuroleptic medications are a good example of that. It's difficult to maintain sobriety when you're surrounded by those that are currently using. And it's also difficult, if not impossible, to maintain medications. Refrigeration for insulin is a good example of that. So now let's focus on some more positive data. We see that integration of primary care improves diagnosis and treatment of chronic diseases, and that results in a reduction in emergency and inpatient admission rates. We found that outreach has been successful in providing initial access to care. We do this by targeting populations because we found that targeted populations respond better than systems that wait passively for patients to discover them. This is where mobile units really come into play and have played a key role in access to care for underserved patients. We found that personnel that work better in isolated environments are a better fit for things like mobile units because oftentimes mobile equals isolated just geographically. Distrust is very common in the underserved population, and it takes time to break down defenses. When a mobile unit parks outside the rescue mission, and we're there every day for weeks on end, people come to trust us, and we've actually been able to make contact with patients that haven't accessed healthcare systems in over 20 years. We found that coordination and communication between team members is crucial. And we also found that respite or convalescent care is critical in reducing readmission rates because of failed treatment plans. Some things to be proud of. Homeless care pioneered the use of EHRs, electronic health records, and this started a decade before the Affordable Care Act pushed for the use of EHRs. Homeless care also pioneered the use of the team approach in medicine. Dentists, mental health, primary care providers, all being on one team for one patient as a result of homeless care. We also played a key role in the development of transitional care due to the shorter admission lengths that most hospitals have now. We also were a key factor in developing mobile units. So that's some background information, and I guess I could wrap up by saying, if I was king for a day, if I had a magic wand, I would like to see things change, especially in medical training. I'd love to see specialized practice, at least homeless care or underserved care, being treated as a specialized practice and being included in all aspects of training. I would also like to see a reliable funding source put in play. So now that this video is over, let's take a break and talk about issues that you want to follow up on in person. Thanks for your attention.